It's Dr. Bill Tulo, Chief Medical Officer at Oculus, and welcome to the Oculus Clinical Webinar Series. Tonight, I am very excited to have our guest speaker, Dr. Michael Belin. The title of our presentation is Applications of the BAD, Belin ABCD Progression Display, and the soon-to-be-released BAD version 4. Some housekeeping. If you have questions, please place them into the chat, and we'll answer as many of those questions we can at the end of the presentation, time permitting. Otherwise, we'll answer them via email. Before I introduce Dr. Michael Belin, let me tell you a little bit about his bio. Dr. Belin attended Northwestern University, majoring in biomedical engineering, and received his medical degree from Rutgers Medical School. He completed internship and residency at the Albany Medical College and fellowship in corneal and external diseases at the University of Iowa. He subsequently completed a traveling fellowship from the Royal College of Surgeons of England Foundation. Dr. Belin is professor of ophthalmology and vision science at the University of Arizona Department of Ophthalmology. He's past president of the Cornea Society and vice president for international development. He's a fellow of the Royal Australian and New Zealand College of Ophthalmology and past chair of the OPO Fellowship Compliance Committee. Dr. Belin's a recipient of the American Academy of Ophthalmology Honor Award, the Senior Honor Award, the Academy Service Award, Achievements Award, and Lifetime Achievement Award. He's published over 180 peer-reviewed articles and presented over 250 papers at major national and international meetings. With no further ado, Dr. Michael Belin, take it away.
Thank you. As Bill has mentioned, what we're going to be going over this evening is a little bit about the current BAD display, about the ABCD progression display, and to let you know what to expect on the soon-to-be-released version 4 of the BAD. So first, the BAD version 4 will actually have a new name. And why is that? It will be changed from the Belin Ambrosia Enhanced Ectasia display to just the Belin Ambrosia display, or the BAD display. Now, you may think that was done just to kind of simplify it, but it was really done for another reason. And that is, there's a prior misconception that the BAD display in itself is specific for keratoconus, and it is not by itself specific for keratoconus. It was originally developed for refractive screening, and it was developed to separate normal from abnormal, and that abnormal could be from almost any cause, keratoconus being one of them, but there are many other things that would give you an abnormal reading on the BAD display. For those of you who may be old enough, this is a picture of actually the first version of the BAD. You'll see the familiar vertical columns of the anterior elevation and the posterior elevation. You'll see the second row, which is the enhanced reference surface, and you'll see the pachymetric progression graph, very similar to what you have now. But what you'll notice is that there's no overall reading. In other words, there's no D values, and none of the indices are color-coded other than just the coverage. As I mentioned, the display wasn't designed specifically for keratoconus. It was designed to separate normal from abnormal. The final D shows variance from normal, but not necessarily keratoconus by itself. And if you look at these examples, the lower left is a post-refractive eye. Obviously, that's not a normal cornea. You'll see, excuse me, flattening on the anterior elevation map, a normal posterior elevation, but corneal thinning in the upper right. And you'll notice the overall reading, the final D on the lower right, is abnormal, as it should be, because it's not a normal cornea. If you look at the upper right, that can look like keratoconus because it's a hyperopic LASIK. You'll see steepening on the anterior elevation map. And again, you'll see an abnormal final D. And the bottom right you'll notice if you look at the pachymetric tracing, particularly the PTI graph, you notice it is almost completely flat. That's because there's endothelial dysfunction and the cornea has lost its normal transition from thinnest point to the periphery, where there's very little difference now in the central cornea versus the periphery. You have corneal edema here, and again, that is an abnormal reading. In addition to my work with Oculus, I am also Chief Medical Officer of Epion Therapeutics, and we are currently in a phase 3 FDA study on epithelium-on cross-linking. And we use the bad display as one of the major entrance criteria for the study. And I just went through how the bad is not specific for keratoconus. So how can we use it as an inclusion criteria? Well, it is correct. The bad alone, the final D in itself, shows variance from normal. But to make it specific for keratoconus, our inclusion criteria included a bad D greater than or equal to 4, but 2 additional things. We have posterior elevation at the thinnest point and an abnormal PTI tracing. The addition of those 2 parameters really takes out the other potential abnormalities. So again, the real one you want to exclude is endothelial dysfunction. And here again, you can see we use a final D greater than or equal to 4, but we add posterior elevation at the thinnest point greater than 13 microns and an abnormal PTI tracing. So again, when you add some additional criteria to the bad, you'll see it's not only abnormal, we can then make it specific for ectatic disease. So if we compare all the past iterations of the bad, I already mentioned, if you look at the one on the far left, that's the version 1. There was no regression analysis. There was no overall reading of the map. It did present the anterior and posterior elevation with the standard reference sphere, the enhanced reference sphere, and it did present you with the pachymetric progression graphs. But again, no overall reading, no deep parameters, and none of the parameters were color-coded. Version 2 was released in 2010, and that was the first version that actually, I guess nowadays you would say, used artificial intelligence. It used 5 parameters in the regression analysis to give you an overall reading. Those 5 parameters are actually on the bottom, and they were the anterior elevation, posterior elevation, pachymetric progression, displacement of the thinnest point, and the actual thinnest point. Each of those were used in a regression analysis. Each parameter was weighted differently. That's what you do with the regression analysis. And then you got an overall reading. In addition, every parameter, not just the 5 that were used in the regression analysis, but every parameter was color-coded and would change yellow at 1.6 standard deviation and would turn to red at 2.6 standard deviation. That applies to all the individual parameters, but not the overall final D, which I'll discuss later. 2 years later, version 3, which is the version most of you are currently using, we improved on the regression analysis by adding 4 additional parameters. Now, all those parameters don't show up on the bottom of the display. You just can't fit everything there. But I will go over what we added. If we look at version 2, for those of you who are familiar with the AU-ROC curves, if you look at version 2 to version 3, it doesn't look like there's a whole lot of change. But actually, that is a very significant improvement. When you get very close to 100%, small incremental improvements really make a dramatic change. And I kind of use this analogy of airplane crashes. If taking off a plane had a 1 in a million chance of crashing, and I'm able to do an improvement to change that 1 in a million to 1 in 2 million, graphically that would look very different, but I cut the risk in half. That is a very big difference. And if instead of looking at the area under the curve, if you look at the top left corner, consider that the risk area. You'll notice that going from the blue to the red, we almost cut the risk area in half. So that really represents a very significant improvement. What were the changes that were made? We added 4 additional parameters. Again, this is version 3, which is the version I believe all of you are currently using. We added elevation at the thinnest point, both at the anterior surface and at the posterior surface. We added ART max, which is ambrosia relational thickness, is another pachymetric progression parameter. And we added K max. I'll discuss K max a little bit later. Addition, version 3 introduced a hyperopic database. The hyperopic database is meant to be used in any patient that has any axis that's hyperopic. So that means hyperopia and or mixed astigmatism. And that was because on some work that we published a number of years ago, we actually showed that patients with hyperopia or mixed astigmatism have different normal values than either a normal or a myopic population. Version 3 also allowed you to actually click on any parameter with a right click, and you'll see there's a little yellow triangle, and that will open up a dialog box that actually will tell you about that parameter. In addition, I mentioned that all these parameters are color-coded. You do have the option to turn off the color coding for all parameter except for the overall final reading. The only reason people would want to turn off the colors is sometimes some people are concerned because you can actually have a single red parameter or a few yellow parameters, but still have an overall normal reading. And some people, for medical legal reasons, don't want to have something that looks red on the map, even though the map's overall reading is normal. And the analogy of that would be kind of the patient comes into your office with a pressure of 22. Well, that's slightly outside the normal range. So if that was color-coded, that may be yellow. But they have a cup to dis of 0.1. They have a normal visual field, normal, no fiber layer, and no family history. That person doesn't have glaucoma. But if you were color-coded these parameter, that IOP would show outside the normal range. So for most times, I suggest you leave the colors on. It just makes it easier to visualize. And I mentioned we only added 4 additional parameters. We only added parameters that improve the overall performance. And these are a number of different parameters. You can see individually, each parameter doesn't perform nearly as well as the overall final D. And again, that's the benefit of a regression analysis. I say here that only parameters that improve performance are added. Well, that's not completely true. Kmax actually did nothing to the regression analysis. It was just that people kept asking for Kmax because they were used to using it. But actually, if you look at the ROC curve of Kmax, it's actually a very poor performing parameter. And it's a very low weighted parameter in the regression analysis. So again, this is the current version BAD3. Again, you can see the 5 original parameters on the lower part. In this case, this is a very abnormal cornea, so they're all red. But you'll notice if you look in, I don't know if my pointer works on the screen. Can someone tell me if it does work? Guess no one's responding. But you'll notice all these other parameters. Okay, you know, Kmax here, front elevation, these are all color-coded. Every parameter is actually color-coded. But again, not every parameter is used in the regression analysis. So the features of the BAD3, again, the one that you're currently using, again, 9 parameters in a regression analysis. Each of the 9 parameters, and actually every parameter on the screen, is reported as a standard deviation. They turn yellow at 1.6 or greater and red at 2.6. And as I mentioned already, other parameters not used in the regression analysis are also reported in standard deviation. Then there's a final D, which represents the overall reading based on a proprietary regression formula. It is important to realize the final D is not a standard deviation. It's a weighted reading of 9 parameters. That is not a standard deviation. It turns yellow at that same 1.6, but turns red at 3.0 or greater. And that's a proprietary algorithmic proprietary scale. So I had alluded to earlier that the display in itself is not specific. In other words, that final D is not necessarily specific for keratoconus. And there needs to be an understanding of the difference between refractive screening and actually diagnosing disease. So the goal of refractive screening is really to evaluate risk or to minimize risk and to eliminate those patients at risk for developing post-refractive ectasia. I would say that most people would be glad to accept a 5% false positive rate to lower the risk of post-LASIK ectasia. So here, sensitivity has greater weight than specificity. And though I hate giving a specific number, most people, if you read articles, use a final D cutoff of 1.6. We'll discuss that later. But diagnosing disease is very different. Here, specificity is most important. And based on an article I published many, many years ago, when you have a final D of 2.7 or greater, it's highly specific for ectatic disease, as long as you exclude other conditions like corneal edema, terians, etc. Now, why is this important? Well, we say a 5% false positive rate would be considered for a refractive practice. So let's say you were screening 1,000 patients and you had a 5% false positive rate. That means you would exclude 50 patients. And let's say, just to make the numbers easy, keratoconus occurs in 1 in 1,000. We know it's more frequent than that, but just makes the number easy. However, if you were doing a study where you were treating keratoconus patients and you had a 5% false positive rate in 1,000 patients, you would have 50 patients you would treat, but only 1 would actually have disease. So you would have no way to really know the validity of your treatment because 49 of those 50 patients are normal. So again, there's a big difference between screening and diagnosing. Screening, a 5% false positive, is pretty much what most of us will accept. But when we're doing a disease-specific treatment, specificity becomes very, very important. And again, going back to that earlier slide that I showed you, we use actually a final D of 4 and add that abnormal PTI tracing and add an abnormal posterior elevation at the thinnest point, because in an FDA trial, we have to be very, very sure that we are actually treating disease. So there's some frequent questions I get, particularly about how do I interpret the bad if I can't get a full 8 millimeters coverage. And let me see if I can back up for a second. See how much, yeah. So you'll notice here, this tells you the number up here, how much coverage you're getting. And the display is based on getting 8 millimeters of coverage. At times, necessarily may not be able to get 8 millimeters of coverage. Full coverage may be difficult, and actually sometimes common in abnormal corneas, again, like keratoconus, in older patients with lid laxity, in Asian populations or individuals with smaller eyes or orbits, and obviously in poorly cooperative patients. So how do you interpret if you don't get a full 8 millimeters of coverage? So let me use one example first. And how do I, let's say I'm following a patient with keratoconus, and when we're imaging keratoconic patients, you can see here an example, we're only having 7.63 millimeters of coverage on the back surface. Keratoconic patients are notorious through not always getting good coverage, and coverage can vary from exam to exam. Well, that's the benefit of the progression display. The progression display, as opposed to requiring 8 millimeters of coverage, excuse me a second, uses a 3 millimeter optical zone centered on the thinnest point. And it looks at the anterior corneal surface, again, anterior radius of curvature, taken from a 3 millimeter zone at the thinnest point. B is the back or the posterior radius of curvature, again from the 3 millimeter zone at the thinnest point. And the C parameter is the minimal corneal thickness. Because we're only looking at a 3 millimeter zone centered on the thinnest point, we don't require a full 8 millimeters of coverage. In addition, 3 millimeters is almost always obtainable, so each exam can be compared. And here you can see in the bad display, in the progression display, we can look and compare up to 8 exams over time. And it lets you know when you have statistically significant change. In this example, because it's fairly advanced keratoconus, we've selected the red flags. The red flags represent a keratoconic database. And we can show you an 80% statistical significant one-sided confidence interval, though 80% is shown in the hatched lines. The 95% confidence interval is shown as a solid line. And here you can see there's no real change on the anterior surface. There's no real change in the posterior surface. And here on corneal thickness, we see some fluctuation. I would say that the C parameter in my use of this display, I take a little bit with a grain of salt. The reason for that is what we're looking at on these is statistically significant change. And to do that, we had to measure the inherent noise of every measurement. And as we know, corneal thickness actually has some diurnal variation. So sometimes you can actually see changes in thickness based on comparing morning to afternoon, which is less common to be seen on elevation data. So why did we come up with the progression display? Well, I already alluded to that the bad display is designed to separate normal from abnormal. While very useful, not necessarily specific for ectatic disease, really designed for risk analysis. And as I said, it can be used as inclusion criteria for keratoconus studies by adding certain parameters to make it more specific. But the final D shows deviation from normal, but not necessarily progression of disease. The progression display was designed specifically to follow and document progression in a statistically validated method by looking at one-sided confidence intervals. Why one-sided? Because we're only interested if the cornea steepens or thins. It allows for documenting progression in spite of a stable anterior surface, and I'll show you examples, and/or a stable Kmax, and it evaluates each anatomical layer individually. If we look at all the prior progression parameters, we look at this big list, except for pachymetry here, every single one of these were just anterior surface parameters. And we know that the anterior surface is often a late changing surface. And we really want to pick up disease and pick up progressive disease as early as possible. So as I already alluded to, it was very important for us to determine the background noise for each parameter. And you can see here, this is actually the ABCD criteria. And these are the parameters again, the anterior radius of curvature from a 3 millimeter zone at the thinnest point, posterior radius of curvature, 3 millimeter zone at the thinnest point, and the thinnest pachymetry. To determine the inherent noise of these measurements, we decided it was important to study both a normal population and an abnormal population. The normal population, because again, your very early cones, again, subclinical cones, those that have posterior ectasia but a normal anterior surface, or your very young patients, probably mimic a normal population. But your more established patients with more advanced disease, those noise measurements will be closer aligned to, again, the keratoconic database. In addition, your younger patients, pediatric patients, are known to have more rapidly progressive disease. And for those patients, we usually recommend using the, quote, green gates or the normal database, because that'll pick up change earlier. So if you look here, these are, you don't have to really know these numbers, but these are the one-sided confidence intervals. And what you'll notice, the green numbers are always less than the red, because the inherent noise in a normal population is significantly lower than in a keratoconic population. So let's look at a couple examples. This is a 15-year-old, and if you look down at the bottom, you'll see fairly advanced disease. The bad Ds are above 10. And here you'll see we're looking at 5 exams over time. And you'll notice by the second exam, we're well past the 95% confidence interval, and it just continues to get worse. On the posterior surface, again, by the second exam, we're past the 95, and in thickness on the third exam. But if you look at, where is it, Kmax, you'll notice that Kmax continued to get worse. So one can look at this and say, well, this really doesn't have any major advantage. I could have just followed Kmax. But let's look at another example. Here is a 15-year-old, very early keratoconus. If you look at the bad Ds, they're on the order of about 3. And if you look at the anterior surface, there's absolutely no change. And here we're using the green gates because it's a young patient with early disease. But look at the back surface. By the second exam, we're past the 80% confidence interval. And by the third exam, we're well past the 95% confidence interval. Statistically significant change in spite of an absolutely stable Kmax. The reason why Kmax is stable is because the anterior surface is stable. This is when you want to intervene. Here you can stabilize this cornea and preserve visual acuity rather than waiting for the anterior surface to change. Here is another example. 16-year-old, again, fairly early disease. You notice if we look here again at Kmax, 48.9, 49.8, just under that 1 diopter criteria some insurance carriers require. But again, if you look at the progression display, well past the 95% confidence interval on the green gates on the A parameter, well past on the B parameter, and well past on the C parameter. Every single parameter here shows statistically significant change well past the 95% confidence interval, in spite of the fact that Kmax does not meet many insurance carriers' criteria. So we were given the question, that's fine, but what happens after cross-linking? How do you define progression after cross-linking? Because our noise measurements were all done prior to cross-linking. And the current version of the progression display does incorporate post-cross-linking parameters. And they show up as blue gates here. Same thing, 80% confidence interval, 90%, 95% confidence interval. The difference is when we did our noise measurements in a post-cross-linking group, and this was epithelium off, the noise measurements were so unstable prior to 1 year post-op that we couldn't really develop noise measurements that were clinically useful until you were at least one year out. So these blue gates will not appear until you have at least a 1 year post-op exam. And here you'll notice on the far right, bottom right, it says treatment. If you check off when you've done a treatment, that is the black dotted line. That means you've done a cross-linking, and you notice the gates do not appear until you're at least 1 year out. Now, when we get more experience with epithelium on cross-linking, my guess would be those noise measurements will probably become stable earlier, and that will have to be something we'll in the future need to incorporate. Next is, how do I interpret the bad for general screening if I don't get 8 millimeters of coverage? Well, I'll tell you that in general, I've never seen, or I've not made a misclinical interpretation if I have at least 6 millimeters of coverage. But if you look at this example here, I have 7.4 on the anterior surface, but I have below 7 on the posterior surface. Again, for refractive screening, my goal isn't to get a diagnosis, is to know whether it's normal or not. And the one thing you can do if you have a patient that no matter what you do, you can't get full coverage, look at the PTI tracing. The PTI tracing is valid up until the area of coverage. So if you see a PTI tracing, even if it stops, let's say at 5 millimeters, if it's down here, I know that eye is not normal. I may not know exactly what's going on, but I can know it is not normal. So if you have really poor coverage in an uncooperative patient, look at the PTI tracing, and if it's significantly below the 95 confidence interval here, you know you have an abnormal cornea. Finally, how do I compare exams with different total coverage? So let's say I have these two exams. And again, yes, you can do the progression display, but here you'll notice I have full coverage at 8 millimeters. And here I have coverage that's below 8. So I'm not using a full 8 millimeters. My normal values, my elevation values will be different. How do I kind of make a comparison? Well, you can use the compare two exams. But if you look at the compare two exams, here in this case, we actually have full coverage. Each best fit sphere is different between the two exams. This one has a best fit sphere of 7.54. Here it's 5.46. It's kind of like comparing apples and oranges. It's like taking a building and saying which is taller, but one is measured from the street and one is measured from the basement. You have to have the same reference. So if you actually, and most people don't use this, but if you put your clicker over here where it says elevation back or elevation, depending on what you're looking at, and you right click, it will open up a dialog box. And you'll notice there's a little thing in the bottom here that says change reference shape in all exams. If I click on that, you'll notice that, again, I'm blocking it, so I'm going to back up. This one is 7.54. Now when I click change reference shape in all exams, now this is the same best reference surface, 7.54. So I'm making measurements now on the same reference surface. Again, most people don't really use this. The progression display is probably an easier way to interpret change. But if you want to make comparisons of, because you can compare not just elevation, you can compare curvature, you can compare thickness, etc. Finally, let's go into, towards the end, what to expect with the version 4 that hopefully will come out shortly. So what's new in the bad version 4? First, the database was increased dramatically to almost 4,000 eyes from 26 different international sites. It utilizes what we call an optimized logistic regression algorithm. Again, nowadays you would call that refined AI. For those of you who have kind of kept up with the literature, you may have heard the term random forest index. That is another way to interpret data. It is much more complex than a logistic regression algorithm. And version 4 has improved diagnostic accuracy. I'll discuss the difference between the logistic regression algorithm and the random forest index shortly. So as I said, again, we increased the database to almost 4,000 eyes. We actually evaluated 120 different parameters. Only 11 were used in logistic regression analysis. Additional parameters did not improve performance. So again, we looked at 120. Again, more parameters doesn't necessarily mean better performance. It turns out only 11 parameters maximized the ROC curves. And what were those 11? And you'll notice some of them are actually relatively new. The one I want to concentrate on is age. So I've always used age in my clinical interpretation. And when I used to lecture, which I still do when I lecture, I would actually show this and tell people not to copy it because it's just what I did. But I had an age adjustment of the final D in my clinical practice. I would increase the final D for patients below 30 and decreased it if they were above 30. And again, you can imagine if a patient is 60 years old, their chance of post-LASIK ectasia is very, very low. But if you have a patient who's 18, their potential risk is much greater because, again, they may harbor preclinical ectatic disease. Now, this may be a little confusing, but for those of you who are familiar with the TBI, TBI is a tomographic biomechanical index. It has always used age, and people talk about it being inherently advantageous. But when I use my age correction factor to the final D and compared it to the TBI, the performance was identical. And that's why these lines are parallel. So the new version 4 does use age. So why do we use the logistic regression analysis versus a random forest? The random forest is more complex, but actually the logistic regression analysis yielded equal results and equal AUROC. The advantage of logistic regression analysis, it maintains the same current appearance as version 3, so the same end user experience, and that's very, very important. So we can improve the overall performance without you basically having to retrain yourself in something that looks totally different. So what else is new? Prior exams taken with version 3 will be marked, as you can see here on the far right, parentheses V3. They will not be recalculated. And the reason for that is medical legal reasons. Though we don't expect to see much of a difference, you don't want a patient that was previously viewed as normal to suddenly be abnormal. So all your past exams will still show up, but it will tell you it's been computed in version 3. There'll be an updated literature as a drop-down to support the improvements in version 4. And let's look at the overall change. So the table on your upper left is the comparison of version 3 to version 4, comparing normals to clinical ectasia. In other words, normals to patients with known keratoconus. And if you look at the AUROC for version 3, it was 0.994, and for version 4, it was 997. Not a huge change. Sensitivity 96.3 to 97.8, specificity 99 to 99.2. Again, very small incremental improvements. But let's look at the one on the right. This is normal versus what we call very asymmetric ectasia. In other words, patients with known keratoconus in one eye, but topographically normal other eye, topographically normal. Here, you'll notice the version 4 does significantly better. The AUROC went from 0.952 to 0.974. That's a really significant improvement. And again, sensitivity 86.3 to 89, or actually 90, and specificity 94.7 to 96.7 again. So that is really where the major improvement is. And again, the greatest improvement going from version 3 to version 4 was in the most difficult cases. Again, those that we call very asymmetric keratoconus. We hope on correcting this, but version 4 currently does not have a hyperopic mixed cell database. So if your patients are hyperopic and you check off hyperopic, it will still be analyzed using version 3 formula. And hopefully that will be addressed in a soon updated release. So in the end, what changes will you notice going from version 3 to version 4? None. And that's how it should be. The overall improvement in performance, but with the same user interface or same user experience. And again, that is why we went with the logistic regression analysis, because again, it keeps the same user interface. In closing, just to be aware, there are multiple other proposed screening programs or displays. None have gained significant market penetration, and comparative testing is very difficult and often heavily biased. If you use a certain diagnosis for keratoconus, then effectively you're just kind of testing that diagnosis. The only real test that matters really is to stand the test of time. And the bad display has been for almost 15 years the most commonly used refractive screening, and has been really since the introduction in 2008. Thank you.
Michael, thank you very much. What a plethora of information. It's really exciting that we are going to have this update coming out shortly. One of the questions we got, which is more of an Oculus question than a Michael Belin question, but I'm sure you know the answer to this, is will BAD4 work on all versions of Pentacams?
I'll let you answer that. I would assume the answer is yes.
Yeah, the answer is yes. Even the oldest Pentacams that are still in service will still work with the new BAD4 version. So if you're running BAD3, you will be able to update once BAD4 is formally released. Let's take a look at another question we have here. You mentioned that the new BAD4 will be adjusted for age, so we won't have to do any manual adjustments ourselves. Can you comment a little bit about the new parameter for astigmatism? Why was that added, and what shortcomings does it fill?
Again, say shortcomings. It isn't. We just looked at, as I said, 120 parameters. It doesn't really say it. The shortcomings is just what I showed you on the overall improvement, specifically in those what we call very asymmetric ectatic disease. We didn't go into this a priori saying this is what we're going to look at. We looked at 120 parameters, and it itself decided what parameters we needed to look at to get that overall performance. So I would say it's not really dealing with a shortcoming. It's just, again, looking at a large number of parameters and determining what gave us the best overall performance.
With the increase in the database, Michael, to going to that many patients in it, was there a conscious effort to include more patients with higher amounts of astigmatism in the database, or was that not a purposeful, conscious thought?
To be honest, I would have to go look at all the nearly 4,000. There was no, I'll answer it in reverse. There was no concerted effort to eliminate patients. So we didn't, pre-select. Other than that, we had a normal database. So we didn't particularly look for high astigmatism or not look for high astigmatism.
And another question that came across: would you expect a patient that you've been monitoring for years for refractive surgery, and now they're deciding to do it, and now you've upgraded to 4? Would you expect, even though you can't examine the older captures with 4, would you expect, if their Pentacam data basically is stable and hasn't changed, that your final D number will be approximately the same as it was with the 3 version from, say, maybe 6 months or a year earlier?
Okay, so first, I do not know this for sure. When you're running version 4 and you call up an old patient that was analyzed in 3, it will show up like I showed you with a parentheses V3. I do not know for sure that whether it will allow you to do something to reanalyze it where you actively have to do something. I would not anticipate you will see a very significant change, particularly in that group that are you're not going to have a normal eye that's going to show up abnormal.
That's basically what they were trying to ask.
Correct. Yes.
So I guess, I mean, every surgeon has a different risk tolerance, and probably many surgeons have developed a cutoff that for them is a comfortable range. So their cutoffs don't have to change.
Correct. And that was one of the reasons to go with the logistic regression analysis. If you went with random forest index, the whole scaling is different. So that is correct. I would not change what you have done historically in the past. I think the big change you will see on those some unusual cases like we kind of described it, very asymmetric, where some questionable borderline cases will give you a more definitive answer.
And the last question I have here, I know in the past we've talked about the difference between PRK, LASIK, and SMILE, and that you've made some adjustments to your cutoff when you're doing PRK versus LASIK or SMILE. I would assume those adjustments also will not change with going from 3 to 4.
Correct. I think everyone has their own clinical adjustment based for PRK and SMILE, and those should not change.
Excellent. Well, wow, this is a webinar filled with so much material to take in, and it was really presented in such a clear, concise way that it made it easy to digest that volume of information. I do want to thank you so much for taking the time tonight to help educate us, and I'm really excited to have this improvement released in the very near future. So Dr. Belin, thank you so much for coming and educating us tonight.